This talk is sort of directed at everything beyond what you've just heard. I agree with pretty much everything that's been said. But what do you do, here's my disclosures, what do you do when you've got something that may be too big or just in a really bad position? And this is an article from Matt Preventure, Tony Romeo, and the crew that I would encourage you to go back and look at. It's really great for understanding diagnosis, classification, and management of Hill-Sachs lesions, and just really getting into the grading systems and how we look at things. From Pittsburgh here, just this year, this was published, Defining Critical Humeral Bone Loss, the Inferior Craniocaudal Extension. And basically, this article looked at the recurrence rate of patients who had Bankart repair with on-track lesions without remplissage. And we've just heard how important that is, 23.9% recurrence rate. And the patients really at risk were ones who had inferior extension below, as seen on a sagittal view on the MRI, was a very high predictive situation for recurrence. There's been some people that have looked at different techniques in bone grafting this. This is a remplissage style grafting where great big bone block brought in from the back, difficult to do, lots of suture entanglement and so on, but what they defined was an indication depth greater than or equal to 8 millimeters and width greater than or equal to 10 millimeters, which is a pretty big situation. Here's Brian Cole's study, long-term outcomes, and I just mentioned this because these patients, 53% conversion to arthroplasty, but 60% of these patients were intra-articular pain pump chondrolysis. These are not the patients we're talking about, so if you happen upon this article, don't get confused with what we're talking about here, which is just instability. And the next slide. John Sagaya talked about doing an arthroscopic Bankart repair and doing mini open bone grafting with allograft bone graft in the back. And also John Kelly talked about doing an Oates style procedure to fill in these inconveniently located Hill-Sachs lesions. Here's an article that talks about using fresh frozen size matched osteochondral humeral allograft with the snowman press fit technique with perfect restoration of the articular cartilage contour, no compromise in range of motion, and excellent arthroscopic procedure. The problem is that these grafts are very, very hard to get in my hands. So I look to the bone grafting maven of all time, Matt Preventure, who always has the best, latest, and greatest solution. Here he reports his experience using a talus for a reverse Hill-Sachs lesion, and I asked myself, maybe I could use that in the back of the shoulder. Here's a 17-year-old football player, small-town star, never leaves the field. He had 2 subluxations he can remember, lots of symptoms, never had surgery, thinks he wants to be a Marine. You see a little defect off the glenoid, one off the humeral head, so you got bipolar disease. The MRI says he's got a displaced osteochondral fragment, which is just the beginning of these problems. CT scan and STL reconstruction of the humeral head demonstrates a 21 millimeter long by 12 millimeter wide lesion that extends down a bit. And the glenoid says 11% bone loss, and the radiologist so kindly says to me this is an on-track lesion with 11% bone loss. Here we are in there, and we can see that the lesion is, there's a big bridge between where we are, where the defect is, and so on. So I elected to bone graft this. Here we did a capsule release. Now we're drilling out the hole inferiorly, placing our first plug, bringing in our second wire, impacting our second plug, and there's your snowman with excellent congruity. And you're able to do this all through the posterior portal that's basically extended to get your portals in, and there's your snowman. So a couple of tricks here. Alignment is absolutely everything if you're going to try this. You can see here plug number 1, I drew out a line using a marking pen. The pin is headed inferiorly on plug number 1, and plug number 2 is more superiorly. They're quite divergent, but yet you end up getting congruity. The other thing about talus is it's readily available, and the cartilage is everywhere, so it's a very generous graft that you can get plugs that you think were going to work best for your situation. And again, this is a 12 by 8 millimeter plug and a 10 by 8 millimeter plug, and we did this through a 3 centimeter incision posteriorly. So this is a nice situation where you can address those very inconvenient centrally located Hill-Sachs defects. In this particular case, I threw the belt and suspenders at this kid. I flipped him over and did an open ladder J with an open Bankart repair and an open capsular shift. And you can see here, here's your graft, and he did great, unbelievable. Parting thoughts, whether it's on track or off track lesion, I think you gotta be worried about these patients because these are the ones that are really gonna have trouble. Depth greater than or equal to 8 millimeters, width over 10 millimeters, extends down below the equator of the humeral head, and these big cartilage bridges where the cuff comes into the humeral head and these Hill-Sachs lesions are in the center. The Oates procedure is nice because you can come in from the back arthroscopically. The talus is extremely generous in terms of where you want to take the plugs. And I'd recommend being aggressive about treating all the other pathology in the shoulder because if there's one that's going to fail, this is the kid that's going to give you trouble. Thank you.